Recurrent respiratory papillomatosis is a potential life-threatening disease characterized by the development of papilloma anywhere in the respiratory tract from nasal vestibule to the terminal bronchi. Predominant sites are where there is change of epithelium from squamous to ciliated epithelium. So it mainly occur at the site where epithelium from squamous stratified epithelium changes to ciliated epithelium like tonsillar pillars, uvula, vocal folds, and laryngeal commissure. These are the predominant site or common site of recurrent respiratory papillomatosis. RRP having bimodal age presentation. It's common between 3 to 4 year of age and equal between male and female during that time. And another peak is between 20 to 30 year of age, that is incidence is 3 male is to 2 female. So it's adult type of respiratory papillomatis common in the male, whereas juvenile onset recurrent respiratory papillomatosis are common or equal in the male and female. So first peak is between 3 to 4 year of age, that is known as juvenile onset recurrent respiratory papillomatosis, while second peak is between 20 to 30 year of age, that is known as adult onset respiratory papillomatosis. Causative agent of recurrent respiratory papillomatosis is human papillomavirus, that is naked double stranded DNA virus about 50 to 55 nanometer in size, and it is under Papillomavirus family. There are over 200 subtypes has been identified, and most of them are non-enveloped virus. So this recurrent respiratory papillomavirus mainly associated with type 6, type 11, type 16. So 6, 11, 16 are associated with the recurrent respiratory papillomatosis. 6 and 11 are also associated with acuminata condylomata, and 16 or 18 are associated with carcinogenesis, that is mainly uterine carcinoma and head and neck carcinoma. Pathogenesis. This human papillomavirus incubation period is about 2 to 3 months. It enters in the traumatic epithelium where it resides in the basal membrane, and it replicates in basal membrane. This process is known as episomal maintenance. As you know, episomes are extra chromosomal DNA that are larger than the normal DNA. Vertical transmission is common from mother to child. Incidence about 4 in 1 lakh children, and it is classically present in young mother who belong to lower socioeconomic class and mostly having vaginal delivery. So this prolonging time of vaginal delivery increase the chances of this laryngeal papillomatosis. Latent or active HPV detected in cervical swabs is about 10 to 25% of women of childbearing age. HLA-DR-B1 0301 are related with the severity of recurrent respiratory papillomatosis, and vertical transmission is about 10% of cases, and transplacental transmission is 10%. Diagnosis. Any clinical symptom of hoarseness, stridor, chronic cough, choking episode, and recurrent respiratory infections, and failure to thrive, leading to suspicious of recurrent respiratory papillomatosis. Now, establishment of clinical diagnosis by laryngoscopy, either flexible or rigid, with confirmation of histopathological examination of this laryngoscopic tissue from the larynx is the diagnostic of this recurrent respiratory papillomatosis. DD may be asthma, laryngitis, bronchitis, and croup. So these are common DD in the children, that is juvenile onset recurrent respiratory papillomatosis. In larynx, most common site is vocal fold, about 50 to 55% of cases. Then second site is antecommissure, about 40% of cases. Subglottis and supraglottis are less common, about 2 to 5% of the cases. On macroscopically, you can see these are wart-like multiple irregular papilloma, that is friable and pinkish in color. On microscopy, there are exophytic projections of keratinized squamous epithelium overlying a fibrovascular core with varying degree of dyskeratosis, parakeratosis, and dysplasia. Coelocytes are cells which are vacuolated cells with clear cytoplasm and can be seen in viral pathology, mainly human papilloma virus. There is two staging system for recurrent respiratory papillomatosis. One is Derke and Cotrera staging. Second is Dicker staging. This is Derke staging system which score from 0 to 3 according to different sites of lesions. Like 0 is none, 1 is surface lesion, 2 is raised lesion, and 3 is bulky lesions. Site may be involved epiglottis, aryepiglottic fold, false vocal cord, true vocal cord, arytenoid, antecommissure, posterior commissure, subglottis, upper trachea, middle lower bronchi, nose, palate, pharynx, esophagus, lungs, and other site involvement. So this is Derke staging system. Whereas Dicker staging is very simple. Grade 1 is sessile growth, that is sessile growth may be unifocal or multifocal, that is grade 1. Grade 2 is exophytic unifocal growth anywhere in the larynx is grade 2. Grade 3 is exophytic multifocal lesions are grade 3 Dicker staging system. Treatment of this recurrent respiratory papillomatosis is very difficult. No single treatment modality is better than another. Total number of operation may be about 2 to 400. Three modality of treatment is available. Surgical treatment, mainly debulking with microdebrider, coblation, laser. Microdebrider is gold standard. Avoid tracheostomy in these type of papilloma because it may help shedding of the viruses. So if needed tracheostomy, then early deconvolution should be done. Medical treatment mainly focus with interferon alpha, bevacizumab, cidofovir, ribavirin, acyclovir, indole 3 carbinol, and cimetidine. Preventive therapy mainly focus with human papilloma vaccination, that is not widely available, but some vaccine like Cervavix and Gardasil is available, that is effective against virus 16, 18, 6 and 11. Mainly Gardasil is available, that is effective against 16, 18, 6 and 11 viruses. Systemic or intralesional bevacizumab can be given to cases of resistance, or that is recurrent respiratory papillomatosis, that is resistant to multiple surgery. You can add this bevacizumab treatment for these type of cases.